Hello and welcome to another intensive care hotline and intensive care at home live stream emergency questions and answers for families in intensive care and intensive care at home. My name is Patrick Hutzel and I'm the host of the show. Now, first of all, my apologies for the delay. Normally I start those calls at 10:30 a.m. on a Sunday, Sydney, Melbourne time, which is 8:30 p.m. in North America, Eastern Standard Time, 5:30 p.m. on a Saturday afternoon, Pacific time. So apologies for the delay. I have been busy with the client, and that's simply the reason for the delay. Now, what makes me qualified to host a show such as emergency questions and answers for families in intensive care and intensive care at home? Again, my name is Patrick Hutzel. I'm a critical care nurse by background, having worked in critical care nursing for over 25 years in 3 different countries, where I worked as a nurse manager for over 5 years. And I've been consulting and advocating for families in intensive care since 2013 at intensivecarehotline.com. And I can very confidently say that we have saved many lives for our clients and their families. And that is verified on our testimonial section at intensivecarehotline.com. It is also verified on our podcast section at intensivecarehotline.com, where we have done client interviews. So everything that I'm saying here, I can actually back up. So I'm also the founder and managing director of Intensive Care at Home. You can find more information at intensivecareathome.com. With Intensive Care at Home, we are sending our critical care nurses into the home 24 hours a day, predominantly for long-term intensive care patients that are ventilator and tracheostomy dependent, but also home BiPAP, home CPAP without ventilation, tracheostomy care without ventilation, home TPN, home IV fluids, home IV magnesium, home IV potassium infusion, and cough assist management, cough assist machine management, etc. So you can also connect with me live on the StreamYard link here if you want to talk to me. I've sent the StreamYard link in there. And Helene, thank you for joining us. You're saying, glad to be here in order to learn and confirm what I witnessed concerning my beloved late mom. Yes, I know you've been through a lot with your mom, Helene. So now, where do I start today? Like I said, if you have any questions, please type them into the chat pad or connect with me live here on the StreamYard link. Now, let's look at some questions that have come in for intensive care at home in the last week or so. So we had an inquiry maybe a week ago or so. There's a young lady in a hospital in Australia, in Victoria, as a matter of fact, in Victoria, in the state of Victoria. She's a young lady with motor neuron disease, and unfortunately, her motor neuron disease has progressed to the point where she's now BiPAP dependent, and she's in ICU. She's also now got a PEG tube, right? And the reason I want to talk about this specific example is, unfortunately, for anyone with MND, once someone is on BiPAP, MND, motor neuron disease, for anyone that's on BiPAP, the next step usually is that, they might be BiPAP dependent intermittently. They can still have time off the BiPAP, but the bottom line is, as the motor neuron disease unfortunately progresses, they will need either a tracheostomy, because the only other option here is end of life, and the good news here is more and more MND patients actually choose to have a tracheostomy because they choose to have a tracheostomy because that prolongs their life. That's assuming they want that, of course. Now, the good news also is with, MND and tracheostomies, that a service like ours, Intensive Care at Home, can look after them, 24 hours a day with critical care nurses, because at the moment she's in ICU with a PEG tube and BiPAP, and the only way for her to go home is to have critical care nurses 24 hours a day. And that makes a lot of sense, So we have done now a nursing assessment to confirm that, and then we will be helping MND Victoria, the advocacy group for MND patients, to try and get the funding for 24-hour nursing care. So this young lady, I should say, with 2 young kids, can go home, and that's just the bottom line for an MND patients. We have looked after a number of MND patients in the community with intensive care at home who have a tracheostomy, and the only safe way forward here is to have critical care nurses 24 hours a day, because the alternative for those patients is to live, quote unquote, live in intensive care. Well, you may as well let them live at home in the comfort of their own home, surrounded by their families, with critical care nurses at home 24 hours a day. What that ties into as well is, we are currently, as part of our membership for intensivecarehotline.com, we have a membership for families in intensive care. We're currently having a member in the US who has their sister in ICU with cerebral palsy, also ventilator and tracheostomy dependent. And she wanted to take her sister home a few weeks ago. And we said, well, she should only go home with critical care nurses 24 hours a day. Now, we're not in the US yet, but what we can say is that if someone is stuck in ICU on a ventilator with a tracheostomy, it doesn't really matter where it is around the world. If someone wants to go home and is medically stable, the only way for them to go home is with critical care nurses 24 hours a day. Now, because of the location that this lady is in, there are no services available. And whilst we can provide private nurses in the US, it just hasn't happened in this situation. And of course, the sister bounced back into ICU in no time, and it's probably glad to say she didn't die, because the risk that if you don't have those critical care nurses at home 24 hours a day, the risk that someone dies or has a medical emergency is huge, right? And what I'm saying here is evidence-based, actually. So if you look on our website at intensivecareathome.com, you will actually find a section there where it says the mechanical home ventilation guidelines. And the mechanical home ventilation guidelines clearly say that only critical care nurses with a minimum of 2 years critical care nursing experience, ideally with a postgraduate critical care nursing qualification, can safely look after a critically ill patient at home with a ventilator and tracheostomy. But also for someone with a ventilator and without tracheostomy, like BiPAP or CPAP, or on the other hand, for someone with a tracheostomy and no ventilator, right? At the end of the day, all of those situations are unstable airways, right? They're unstable airways, and an unstable airway needs to be managed by nurses who have the skill to manage that, right? There's no 2 ways about it. If you don't have that skill, patients have died, and I can have evidence for what I'm saying here, right? That patients that do not have that 24-hour critical care nurse have died, right? Here's another situation from a member that's just come up in the last few weeks. One of our members has their daughter, their 36 or 39-year-old daughter, in ICU with a tracheostomy dependent on dialysis for 2 years. For 2 years. I'm not joking, right? And this family is absolutely determined to get their daughter home, and we are in the process of helping them. And the good news here is that more and more families, as well as more and more hospitals, are starting to think what they think is outside of the box, whereas I don't think we're thinking outside of the box. I think we're thinking logically, and I think we're thinking common sense to get patients and their families home if they are in intensive care for prolonged periods of time, right? And, people in hospitals are busy. They can't see the wood for the trees, right? And they don't even think laterally. Probably I should say we're thinking laterally rather than thinking outside of the box, to get patients home. If they're medically stable, if they're having a ventilator, tracheostomy, if they're off inotropes, off vasopressors, going home with a tracheostomy and dialysis, it can be done. But it has to be done for the sake of patients and families, but it also has to be done for the sake of hospitals to free up their precious beds, The most sought after bed in a hospital is the intensive care bed. And I can talk about this all day long because, I believe we are so immersed into this space. And, we have given it so much thought about what needs to happen for patients, for long-term patients in intensive care. And just for the latest situation that I've given you, where our member's daughter has been in intensive care for over 2 years, the ICU has told her she can't go home because she's non-verbal. She can't talk. I mean, that's just ridiculous. It's just a joke. Most of our clients are non-verbal, unfortunately. As long as there's someone that can speak for them, and as long as there's someone who can advocate for them, that's more than enough for them to go home. For someone to say they can't go home because they're non-verbal, I mean, that's just a joke. Yes, the email actually from our member where she says, I want my daughter home. I can see that from your information. You can help me so she can get the support she needs. I want her home. I think she will recover better being around her loved ones. But the nephrologist will not allow her to come home to do her dialysis. He said that because of her, she's unable to tell anyone that she's in pain. It's the reason that he will not allow her to come home. Is there any way to fix this issue? She has a tracheostomy, she's on dialysis, and she has a brain injury, right? Of course, like I said, of course she can go home. This is completely ridiculous for a nephrologist to say she can't go home because she can't tell anyone when she's in pain. Well, nurses and doctors are actually skilled to read nonverbal pain signs, right? That's part of what we do as nurses, and plenty of patients in hospital that can't tell anyone when they're in pain, and then it's up to the skill of doctors and nurses to find out when they're in pain and manage it accordingly, right? It is not rocket science. It is not about rocket science. And with all of that said, I also want to read out a post that I saw on LinkedIn the other day. This ties right in with this last example that I've given you, where this lady is begging us to help her to get her daughter home after 2 years, right? And I saw this post on LinkedIn for someone that's talked about advanced care plans, and many of our clients do have advanced care plans, many don't, but it is always good, especially when it comes sort of to chronic illness, long-term illness, to have advanced care plans to what you want. And this post on LinkedIn from Tim Dallinger, and I don't know even who he is. It says he's a social care consultant, but someone tagged me into that screenshot, and it says, when he talks about advanced care plans, whether it's in ICU or anywhere else, he says, talk about what matters to me, not what matters to you. And this is what this nephrologist is doing. He talks about what matters to him. He wants to keep our member's daughter in hospital. Why? Why? For your own ego? Then he says, write and talk about my needs as they affect me, not about how they affect other people. My experience is unique to me, right? Again, this is all about what the doctor wants. It's not about what the patient and the family wants. Next, he says, focus on meeting my outcomes rather than on your outcomes. This is an outcome the nephrologist wants. The outcome the nephrology wants is to keep her in hospital. And in the meantime, this family is getting desperate to get her home, understandably so, especially since there are solutions here. It's not that the solutions aren't here. Then he says, be risk enabling rather than risk averse. Again, from a hospital's perspective, intensive care at home might be a perceived high risk, but what is it? It's just a perception, right? I don't think that we are enabling risk here. I think we are enabling safety, just in a different environment. But we're also enabling common sense by taking someone home rather than leaving them in hospital for another 2 years. Number 5, he says, explain to people who don't know me how I like to be cared for. I think that's an important one. I'll read that out again. Explain to people who don't know me how I like to be cared for. Well, clearly, this lady wants to be cared for at home. The family wants her to be cared for at home. Again, common sense. Number 6, he says, make sure that my care plan is consistent with any risk management plan. Absolutely. And this is, again, what we do at Intensive Care at Home. It's all about managing the risk. It's all about putting the right people and the right resources in place to manage the risk. Number 7, he says, don't write or talk about stuff in more than one care plan section. That just confuses people. I agree. Care plans are there to be succinct. They're sections, different sections, and they're there to be succinct. Number 8, review my care needs with me. Did you hear me? With me. Right? Again, let me repeat this, because I do believe that's where hospitals often get it wrong. Review my care needs with me. Did you hear me? With me. And again, this particular hospital here is not doing that. They're just saying she can't go home because she can't talk. Most patients in ICU can't talk, and they're still going home at some point, even if they continue not be able to talk. Number 9, don't write care or clinical notes in my care plan. There is a proper place for them, and it isn't in my care plan. That's fair enough. I've got nothing to add there. And number 10, he says, remember that it's my plan. It's about me. It's about my needs. You have to get it right because I depend on you for my care. I thought that was a really great post that I saw on LinkedIn the other day about care plans and what's important to people, right? And because it is about people. It is not about hospitals. It is about what's best for people and what they perceive to be best. And it has to be safe, of course. But home care is safe. It is actually very safe. It just needs the right structure and right framework. So, are there any questions so far? Because today I will only be able to do another 15 minutes because, usually I allocate about an hour for this YouTube live, but because my schedule was turned upside down, I only have another 15 minutes. So if you have any questions, please type them into the chat pad or connect with me live here on the StreamYard link. I posted the StreamYard link into the chat pad. Now, that also leads me to how does an intensive care consultant or intensive care specialist improve the quality of life for our clients and their families at home? Because, we don't have an intensive care specialist for all clients, but we have an intensive care specialist for some clients where it makes sense. And one of the questions that we had come up recently from a funding body was, how would an intensive care specialist improve the quality of life for our clients and their families? And clearly, the first advantage of having an intensive care specialist oversee the clients for our care, of the care for our clients, is that it avoids and minimizes hospital readmissions. Not that we have lots of hospital readmissions anyway. However, we are seeing now that with a particular client where we are using our intensive care specialist and intensive care consultant, that the number of hospital readmissions has come down significantly. And even if it's only for an ED, for an emergency department presentation, because we can do that at home now. So that is one of the main reasons why an intensive care specialist is improving the quality care for our clients in a home care environment, right? Number 2, it's also a win-win for the local ICU by us having an intensive care specialist involved, right? The ICU, it takes the pressure off the ICU, right? Number two, it just improves and increases the communication, the speed of communication between the team, our intensive care nursing team, and the consultant, and things just get done quicker. Now, the other thing is that we can do IV fluids at home much easier. We were able to do them before, but we can just do it much quicker now, right? Much quicker now. You know, IV fluids, IV antibiotics, right? We can do IV antibiotics much quicker, right? So there are so many advantages of this. You know, it also increases and improves speed of communication between other specialists by having an intensive care specialist involved, right? So also it improves speed to talk between hospitals and us. You know, also increases speed to talk to hospitals and the ambulance, and or ambulance between us, and it avoids ambulance calls as well, right? So again, it does improve the length of time that clients can stay at home. It minimizes costs in hospitals. It minimizes costs for ambulance call outs, right? So there are only advantages by having an intensive care specialist involved in the care of our clients, right? There's no question about that. Also, it increases, you know, the skills of our staff. You know, our staff are highly skilled, but, you know, it's always good to have an intensive care doctor involved that, you know, is familiar with intensive care at home, and that has also bought into the philosophy of intensive care at home, right? So there's only advantages coming out of having an intensive care specialist involved in the care of our clients, right? And again, the hospitals will benefit from that because there are fewer hospital readmissions, as simple as that. Okay, other questions that have, or other things that I want to address is simply the effectiveness of intensive care at home. You know, we are saving half of the cost of an intensive care bed when hospitals are using intensive care at home, or when funding bodies are using intensive care at home, right? With saving half of the cost of an intensive care bed, plus we are freeing up the most sought after bed in intensive care, or in a hospital, which is the intensive care bed, right? Now, I've also had another inquiry this week where someone was asking me whether it's possible for their dad to go home from ICU, and they sent me the medical records, and I just quickly will open up those medical records so I can actually give everyone an answer there without obviously identifying the client. I just quickly need to open up those medical records. So medical records. So this client, again, has been in ICU since the 5th of February, which is over 3 months now, coming close to 4 months. And it's good that, you know, that families are looking up online what else is possible and just taking for gospel that a patient needs to stay in intensive care indefinitely. So, I'm sorry, it's just taking a moment for the medical records to open. But, you know, it's good that patients and families are taking initiative. It's good that hospitals are now taking initiative and see as intensive care at home as a viable option. You know, it's also the ICU that I was talking about this MND patient a minute ago. It's also the ICU. They're clearly saying, look, if we could use intensive care at home to get this lady home, it would free up one of our beds. Again, using common sense instead of hospital bureaucracy. Especially this young lady has a young family, and her children need to be by her, and they're living about 2 hours away from the hospital. Patrick, what do you think? Why Medicare states patients can do peer-to-peer hospital transfer, but it is not honored? We trade of trust. Yes, I know what you mean. I can tell you, Elaine, this week, I actually had a phone call from a prospective client who had a similar situation. He wanted to have his mum out of hospital as quickly as possible. And what he did was, and he wanted to have her go to another hospital, he called 911. This was in the US. He called 911 and he put his mum into on a stretcher with an ambulance and sent her to another hospital, and they admitted her. So, Helen, I'm very big on people taking responsibility for outcomes. This gentleman took matters in his own hands and he got the outcome that he wanted. Right? The system is broken, we know that, but that doesn't mean we stop trying. It doesn't mean we stop trying, and it doesn't mean that focus on the things that you can control. Focus on the things that you can control, not on the things that you can't control. Well, he was able to control calling 911, and he was able to call another hospital and saying, hey, I'm sending my mom to your emergency room right now. This is a situation. Would you take her? Right? So take matters in your own hands. Work around the system. So the file is finally open. So the patient is previous hospital, transferred to ER from home with altered mental status, 85-year-old man with past medical history significant of hypertension, CAD, cabbage, COPD, history of TBI with ischemic heart disease, community hydrocephalus dysphagia, status post-PEC, chronic kidney disease, was admitted on the 30th of January after presenting from home with altered mental status and shortness of breath. So now, initially it was on BiPAP, then he ended up with an aspiration pneumonia. He had a high troponin, which indicates he had a heart attack as well. And now he is having a tracheostomy, which he's had since early March. Aspiration pneumonia, recovered from that. He had a STEMI, and now the family is wanting him at home. And so, and as far as I can see by just skimming over the medical records, he can go home, right? Because he's medically stable. He's not on any inotropes, vasopressors. He doesn't seem to be ventilated right now, but he is with a tracheostomy, right? And as long as he's not on inotropes, he can be transferred home from ICU with intensive care nurses 24 hours a day, cutting the cost of an intensive care bed by around 50%, right? So it's time for this man to leave ICU after 3 or 4 months. Everything that's done in ICU in this situation can be done at home. All you need is a critical care setup at home. That's all it is. No more complicated than that. You need the right mindset. You need the right support structure, of course, but the mindset is absolutely critical. He's also not on any oxygen, right? So that's really good. That helps. And I can just see now as I'm scrolling down, he is still on intermittent ventilation. But even so, doesn't really matter that he is on intermittent ventilation. Again, that's something we can do. He's in a volume control mode. He's on a PEEP of 5. He total volume of 350. He's on room air. He is can't see the rate. Actually can't see whether he's on a rate or what the rate is, but in any case, it doesn't really matter what rate he's on. You know, it is something that we can do at home. You know, and we can also continue ventilator weaning if that's where this man is up to. You know, if anything, ventilation weaning is often easier at home because patients are more relaxed. They're in their own environment. They're also often more compliant than in a hospital. Right? He's got a size 7 tracheostomy, a Shiley. That means he's got an inner cannula. But again, we can change inner cannulas. There is no issue there. So, you know, one way that I like to approach new clients as well as they transfer from hospitals, you know, there's no need to overcomplicate. You know, there is no need to overcomplicate. It's really a case of getting the right staff to the right clients, making sure they've got the right equipment, then building teams around them. There's really no more than that. So I can see that there's quite a few people here, and I want to thank you for your support, but unfortunately I do need to wrap this up. I do apologize again that I could only do half an hour today. That was due that I had to attend to an urgent client inquiry, working with a client. I do apologize for that, but I'm back next week again. If you need help with intensive care at home, go to intensivecareathome.com. And if you need help for your loved one in ICU, go to intensivecarehotline.com. We're here to help. Thank you so much for watching. This is Patrick Hutzel from intensivecareathome.com and intensivecarehotline.com. Have a wonderful week and look out for my videos that are coming during the week. Thank you so much. Take care, everyone, and have a wonderful weekend. Thank you.